Good afternoon, good morning, welcome. Thanks for joining us today for some exciting time talking about workforce data. I'm Allison Ave-Sekera. I'm the VP of Training and Programs here at the Association of Clinicians for the Underserved. I am honored that you've decided to join me for this webinar today. Thanks for making the time. I'm going to keep it quick. I'm going to keep it peppy. I know many of you are in the middle of lunch or having lunch or finished lunch and probably ready for a cold day rest of your brains. But today we're going to be exercising those brains, having a good time talking about numbers and strategy, everyone's favorite two things. So just a couple of housekeeping items before we dig into the content here. One, my slides are already available for you. You do not even need to wait to the end of this program. They're in the handouts box in the right side of your GoToMeeting control panel there, so feel free to download those now and throughout, and they will be available afterwards. We are taking questions anytime, all the time, so feel free to put those into the questions box or the chat box. Both of those are being monitored. If you're having any problems at all, you can write something there, or if you have questions about the content. And I'll try and take questions throughout, but we'll definitely leave some dedicated time at the end for questions. And then, of course, the last thing, just want to let you know that we are recording this. So I'm sure you are going to be thrilled at the content and want to share it with your colleagues, friends, loved ones. So we're going to have the archive of this webinar available on our website and some other places, perhaps via email. So stay tuned for that recording, and feel free to know that you're going to be able to revisit this, because we're going to cover a lot of exciting but also a little bit dense material today in this hour. So just know that you can always come back to us, and of course you can always call us anytime. And who is the us, you might ask? I'm talking to you from the Association of Clinicians for the Underserved, that's ACU. We are a national nonprofit focused on the recruitment and retention of clinicians into underserved areas. So we really focus on, for example, National Health Service Corps is our main policy focus, and expanding the Corps and expanding the number of clinicians in underserved areas through that program, as well as offering training, education, ongoing support, and networking for clinicians who are already in underserved areas. So ACU, we're a large membership organization, but we also receive grants, and so that's sort of the hat I'm wearing when I'm talking with you today. ACU receives a national cooperative agreement from the Bureau of Primary Health Care to run our STAR Center, and that's that STAR Center project is what funds the data profiles that you've received via email and are looking to understand. And that means that it's free, my friends. That's right, I wasn't losing my mind after my lunchtime coffee. Everything you're hearing about today is free. We're part of a national network of NCAs that provide a number of free resources, training, and assistance to health centers to help them with anything and everything to make their operations better. Now, we here at ACU and at the STAR Center are specifically focused on clinician recruitment and retention. And we're here on this webinar today to talk about a specific resource, which is our data profile. So I'm going to refrain from going on and on about all the other things that the STAR Center does, but I just encourage you, if you've not visited it already, to visit our website at www.chcworkforce.org to get more information about all the different things that we can do. So this is really the time that you give me a quick sense of who you are on the line, and we're going to have a little poll question that we'll launch here to talk about your previous experience with these data profiles. We want to know, have you worked with previous versions of your organization's data profile? Just a yes or no. We've put together 2 previous versions of these profiles, and we've sort of moved around the date a little bit about when we create and release them. And so now we're more in line with the release of UDS information that comes from BIPIC in late August. But since there's a lot of info contained on the profile and a lot of information we're going to talk about today, we wanted to get a good sense of your starting point so that I can make my content and delivery as relevant as possible. So maybe let's see what the results are here. Great. Wonderful. So we're going to move on to the big show, my friends, and talk about data and why we want to do it. So I love this quote. It can be a little intimidating to folks, but without data, you're just another person with an opinion. Remember that next time you're having an argument with your children or your partners at home. But really, we at the STAR Center are focused on helping health centers create a data-driven workforce strategy, and it starts with that data. There are so many things that can contribute to recruitment and retention challenges. That's a really big topic, really big problem, recruitment, retention. So the idea is really to use data to start to break down the big complicated issues into bite-sized chunks so you can figure out which areas could be high impact for your investment, for your review, for your ongoing time. So in the whole universe of things that affect recruitment and retention, what is the first thing you should do? What are your first steps? What are the things you really need to look at? And that's how we came up with our recruitment and retention data profiles. So there's already a lot of information out about health centers and their workforce, and while some of that data and the way we collect it is not necessarily perfect in process or the exact right thing we want to capture, there's already a lot going on and a lot health centers specifically are reporting on. So we thought we wanted to take the opportunity with the data profile to look at the broader picture of workforce data without asking you to invent something new. In partnership with BIPIC through our NCA, we pulled together these numbers on these data profiles. They are confidential. I'll just say that now. Every single health center receives their own data profile. And then we work with PCOs, primary care offices, and primary care associations in each state. PCAs and PCOs, they can both get access to the individual data profiles, but they have to sign a special data use agreement with us and via the Bureau data use agreement to make sure that that information stays confidential. The data profiles from this year capture 51 different data points from 12 different data sets, and those are all nationally available in some sense, even though, for example, if you're looking at national UDS number, you don't get all of the richness of the data that we have because we have this special arrangement with the Bureau to create these for you. Our goal in creating these was to provide you your own workforce data in one report so that you can have data-driven strategic conversations with your teams about how you're doing, both your successes and your challenges. And that's really all that it is. And not that it's not a lot, but I really want to make sure that you understand that the point is really just to have something that will give you a good data-based place to have discussions about all the context around the recruitment and retention challenges at your health center. All of these problems are, as I mentioned, very complicated and large, and so the idea is just to say, how can I start this work? How can I start to unravel this big ball of challenges into something that I can meaningfully change and make better? And so that's what these are. It's really a starting point for conversation for your team, for your conversations with us here at the STAR Center. And so I hope you're excited by that possibility that by starting with data and starting to have strategic conversations with this free tool, you're going to be able to make strategic, well thought out decisions that's really going to help you change what's going on at your health center. So before I advance to the next slide, I just want you to know that we know it's a lot of numbers, my friend. Don't be scared. Jump into the fray. I'm a recovering English major, and even I have mastered these data profiles, so I know that you can too. Today, with the rest of our time, we are going to be walking through a sample data profile together to demonstrate how to use it, how to read it, and how you might want to actually use it in terms of making something better at your health center. So a quick caveat that this is a little bit of a Frankenstein profile to protect confidentiality. So obviously we changed names, but we pieced together some of the the top data with somebody else's bottom data, so that even if someone tries to figure out, whose numbers these really are, these are all protected. So if you see any small discrepancies, that's because this profile is a bit of a Frankenstein, or Frankenstein's monster, if you want to be precise. I know it's a lot of numbers. Stick with me. We're going to go through this together. So we're going to go through sort of the process at a high level today, and just wanted to remind you that our team is always available for individual walkthroughs of your individual data profile. So don't be shy about requesting a call after this webinar, even though you're going to be experts on how to use it. Feel free to reach out to us. Again, this is just an exercise for all of us. I know we have some state organizations, PCOs and PCAs on the line, as well as lots of health centers. So we just want to make sure you know this is really more about getting a general sense of the thing, and that we are here for free. Said it once, I'll say it again, free individual assistance to walk through the profiles. So that was a quick glance at the sample data profile we're going to use. I also want to mention one of the main things you really need to use this tool is the user guide. So I've included the link here. It's on our website, a number of places. You can email for it. We'll have one of our team put it in the chat box as well, so you can get to it. But the idea really is that the user guide, think of it as your secret decoder ring for understanding every single number on that sheet. All the numbers can look a little bit like a jumble, but this user guide is going to be your buddy. It's going to get you through the tough times and help you understand where exactly everything came from and how you're supposed to really understand it. So we're also going to practice looking at these two things together as we walk through today. Okay, I feel like people are ready. You're excited. You're nervous, but up to the challenge. So we're going to just get started here. And we are going to start, as always, just at the top with our descriptive attributes you'll see. So, this data profile itself, it's like we took a picture of your health center at a specific time on a specific day. And this data profile is that picture. So as you know, things can certainly change quickly at a health center, and we wanted to include some basic descriptive attributes that aren't necessarily only recruitment retention measures, because we wanted to give you some background about what your organization looked like when we took this data picture. So just get you back in the context. I'm going to be mentioning UDS, Uniform Data System Information. As you're all aware, that information gets submitted at the end of the year, and then you don't get it, the results until 9 months later, and so there is a bit of a lag. And we just want to, again, put you back in the shoes and say, who were you when we took this picture? So these descriptive measures, like other sections of the data profile, the whole thing is here for you, and then they're split into two sections, one for the health center and one for the service area. So we're going to flip over to the health center organization piece right now, and you'll see here, hopefully you can follow my little highlighter here. We have stuff that's specific to the health center organization. We have things like number of sites, medical users, percent of non-patient service revenue, whether or not you have EHR, all kinds of things. Again, just to give you a reminder of who you were when we took this snapshot, tends to be the largest thing that will change when this is going on is that a health center organization will have opened a new site between when we took the picture and when they get this profile. So just something to keep in mind. Another reason to include this information is that it has served as a good quality control measure for folks on their own UDS information. So most of this descriptive information is from UDS, and this type of information is the stuff that's most often skipped over when people are submitting and reviewing their UDS. So we receive these numbers directly from BIPIC. If you do see a number that surprises you, I encourage you to go back and check your own UDS submission and say, hey, is this really true? Is this what we're doing? Is this, the most up-to-date that we were when we submitted it? And of course, we're always happy to talk through it individually as we go. And so that's the health center information. I'm not going to dwell because it's just the descriptive attributes, and I'll also quickly just move to the service area information. This service area information offers a nice opportunity to talk with your team about health center operations in general, and also potential to reach more patients. People spend a lot of time on the lines about the percentage of folks in their service area that are covered by Medicaid versus the penetration they have of that Medicaid population. So that tends to be, as we're going through with people, the type of information that's really interesting to teams as they're thinking operations. So please note that what we call your service area is based on the zip codes of the patients that you actually served in the previous year, not the larger thing that you might call your service area, in your scope or your application or whatever. This is really where you got your patients. And to make that clear, we included this map. So obviously this is intentionally blurry for now, but just wanted to give you a sense of what the map is. The dark blue area is what we're calling your service area throughout the profile. And that's where you're getting 75% or more of your patients. The little yellow dots are service sites, and the light blue area is where you've seen at least one patient from those other zip codes. So that's really to give you a sense, again, on the penetration. We chose this map because it's a nice example of what you generally want to see, which is that your dark blue core service area, is formed tightly around those yellow service delivery sites. That's the whole idea, right? You put the health center in the place where people need it and where they can best access that care. So if you're looking at your map and you have a yellow service site dot on your map and there's not a dark blue area around it, also a good chance for you and your team to go back and visit it and say, hey, how are things going at this site? How are we getting these patients? Where are they coming from? What are our opportunities to increase patients in this general area? So with that, then, we slip down to the bottom, and I've broken it up here into the recruitment and the retention side, which is exciting. We've made it to the big time now. The whole bottom half of the profile is dedicated to specifically recruitment and retention data. So as you know, recruitment and retention are linked items. When something changes in one area, it affects something in the other. At some point, we just had to make some decision and break things down as best we can. So we put some data points here in the recruitment section. We put some data points in the retention section. I just want to bring it up now so that you can try and look at each data point through both the recruitment and the retention lens and just get a real sense of, oh, okay, yes, I can see why this is relevant for recruitment, but I also understand why it's relevant for retention. So back on this recruitment side of things, you'll see that we have recruitment here, and then we broke things down again into health center and service area data points. So just remember, the point of all of this is to just use the data to give you little guideposts about where you could best invest your time or energy or money or resources for the most impact on your workforce. So as we unpack things here, you'll see there's a lot to understand. There's a lot that you could know, but the idea is just really to start to use this to have those conversations and figure out how you're going along. So we're going to dive into it here. Recruitment health center, we're going to start, I sort of zoomed us in here. We're going to start with the first 5 here. You'll see the top 4 are NHSC placement percentages. Oh, and I will say these are numbered, but they're just numbered for ease of reference between this and the user guide when you're flipping back and forth. They are not numbered in any specific way about priority or what's most important or any of that. So when I'm mentioning these numbers here, it's really just so when I say recruitment health center number 4, you know what I'm talking about. So you'll see that there's a name describing the data point. That's right here. For example, we'll look at this one. The first one is National Health Service Corps placement percentage of MDDO staff. And what that means for this one and for the first 4 is that we're looking at what percentage of your staff in these different clinical discipline types are receiving National Health Service Corps, and I'll say for the first time. So because of the way National Health Service Corps data is reported, we can't track extensions So if you have someone who received, National Health Service Corps and extended after their initial period, that won't necessarily be reflected here. But luckily, we now have trend data for several years, so it will be reflected on the back page when we get there. But you'll see that it's just the data point and a number here. That's all it is, a data point and a number, a data point and a number, data point and a number. So you'll see some of these are 0. This health center this past year, we saw at the top, they have a HPSA score of 16. They do not have any physician staff starting on National Health Service Corps, but 29% of their nurse practitioner, physician assistant, and certified nurse midwife staff did receive the Corps for the first time that year. So that's how you can start to see, oh, that's interesting. We're using the Corps really heavily for this discipline and not for this other discipline. I wonder why that is. How is that possible? So already you're starting to see, if you see this gray box, that means there was no data for that. For this specific health center we're looking at on this data profile, you're going to see a gray box every time there's psych LCSW, and that's because that health center has reported that they do not have any psychiatrists or LCSWs on staff. So we're always going to have a little gray box for them, but that's what that gray box means. So we're going to skip forward then to the next section, number 6 through 11, and you'll see we have some more numbers. This one, though, looks at National Health Service Corps vacancies. These first 4 here, numbers 6 through 9. So vacancies as a percentage of the staff. This side looks at really its perceived vacancies compared to how many of that type of staff you have. So for this first one, National Health Service Corps vacancies as a percentage of MDDO staff, physician staff, if let's say you have 5 physicians, but you've posted 1 vacancy on the National Health Service Corps jobs board, your number is going to be lower than if you have 5 physicians and you post 5 vacancies. So the more vacancies you have compared to how many staff you actually say you have, that's the higher your number is going to go. So if you have a really high number, that could mean that you have a really, really high need for that type of discipline and you're having a lot of vacancies right now. It could also be due to a number of other things, how your organization is using the jobs board, whether you've had a big event, like maybe you did open a new site and now all of a sudden you have all these vacancies, and it's not because people left, but it's because you have just new opportunities. But all of that is really to capture kind of the perceived need that your specific organization has. So for number 6, this organization's number is 195%. That's so large, and it's in blue. So it's a big number. Why is it so big? That's really something that I can't answer because I just have the data. What I don't have is the context. So if you're at a health center, this is your chance to say, hey, I can solve this problem. Let's look at our numbers and figure out why this number is so big. But I can go ahead and answer the question about why it's highlighted in blue. And now is actually the perfect time for us to skip over to the user guide to understand the blue flags. So the blue flags are there to designate that your health center for that specific number looks pretty different than most of the other health centers in the country. And we know that it looks different because we compared them all on our user guide. So here, that's the one that I mentioned. We have the link in the chat box. That user guide is really very exciting because it gives you all of this other information. Yes, that's right, more numbers, hooray. But let's kind of dive into it and see what we can find out about that blue data point we were just looking at and why it was blue. So we're going to start with this first column over here. I've kind of zoomed in. You can see this is the recruitment health center piece, and this is the column 1 and 2. So column 1 is the measure. So that's really going to mirror exactly what's on the data profile. It's going to be all the same language. And we were looking previously down here at number 6. And that's your National Health Service Corps physician vacancy compared to your current physician staff. Column 2 is going to tell you the source. So we got that from the HRSA Data Warehouse and UDS 2016. HRSA Data Warehouse told us what those National Health Service Corps job board vacancies were that you posted. and UDS 2016 told us how many current physicians you had. So that's where we got those numbers. So you're starting to the picture is becoming a little bit clearer. Okay, we reported this, we used this. And then next comes column 3, which is really the description area. So we're going to go back here to row 6. And so we know now that this data point is telling you the physician vacancy listings as a percentage of your health center's current physician staff. So there's some more detail here, like you can see this is PC, that's primary care, it's explained in the front page. So again, you'll start to get a little more detail, like, oh, we're actually comparing the primary care physicians, not necessarily the gynecologists that are on staff here, the OBGYN. So this description usually has a little more data with little pieces like here, these primary care physician staff, for you to understand a little more of what was included in when we were doing our algorithms. And then the last piece is really the very exciting piece. This specific page is a little less exciting because a lot of health centers have zeros for stuff. But this, what you're looking at right now, is measures and centiles for all health centers across the country. Exciting. So what we did was we ran that data point that we were just looking at, number 6 down there. We ran it for every single health center in the country, and we said, okay, what does it look like? For most of the country, they had 0%. That means really that they had 0 vacancies on the National Health Service Corps Jobs Board. I don't know about you, but lots of health centers I know, friends that I have, they absolutely have vacancies. It's a question for another day about why they're not posting them on the National Health Service Corps. It's called the Health Workforce Connector now. I don't know why they're not posted there. But most health centers, 90% of health centers, didn't have any postings at all. And then when you got to the top 10% of health centers, they had 25% of their postings, 25% of the vacancy to staff rate. That's really the top 10%. And so this health center with 195%, you can see the distribution curve right here. About here's 25%, and our health center that we're looking at is probably right about the top of that graph, saying, you know, we have almost twice as many vacancies as we have positions here at this health center. That's a real problem. Now, again, it could be a problem as in you have tons of vacancies and something major happened. It could also be a problem and there's been an error with how whoever is in charge of the National Health Service Corps postings has posted. Maybe they don't know how to do it right, or they don't know how to delete things, or someone, you know, left the position and no one has the password and they can't get in anymore. So it's also a good opportunity to do some kind of quality control about what's going on there. And so this distribution is really interesting. This row here, for example, is looking at pay, and that's looking at how much a health center pays its total staff, like what their line for salaries is, compared to the median for the for-profit group MGMA that gets done every year, that big data set. And so you'll see, for example, this is the distribution for health centers. So the bottom 10% of health centers are paying, you know, less than 68% of what their competitors are in the for-profit market. That's a challenge. And so we had to go ahead and make this flag threshold column and say, you know, it's not a value judgment, good or bad, but we had to say, we're going to put the numbers in blue of folks that look really different in a way that we think could be the biggest challenge there. So for the one we were looking at, if your number for that data point number 6 was 25% or higher, you were in this part of the curve, your number is in blue. And that's not an indictment of any kind. It's really just to say, hey, you're in this group up here. Maybe that's all fine, but maybe it's not. Let's talk about it. And so this flag threshold column will show you where we gave those little blue flags. So in this example, and the one we were looking at, the flag went to if you were in the top 10%, meaning you had the highest need there. But in this row, when we were looking at pay, we flagged you if you were 68% or below, because we thought, hey, having really low salaries, that's potentially a challenge, right? So there's no right or wrong. There's no golden standard for a lot of these measures. We just made our best guesses about what could be useful information to you. And so a blue flag is really just a chance for you to say, hey, I look pretty different. Let me come to this user guide here and figure out which group I'm in. Is it high? Is it low? How's the rest of the country shaking out? And let me talk to my team and get the context about why that's happening and how we have some chances to improve. So that was the user guide. You're going to want to spend a lot of time with that. We only had an hour here today, so I'm going to move on and just talk you quickly through the rest of some of these measures just to give you a sense of what's here. But you're going to want to spend a lot of time unpacking it on your own with your own profile with the user guide. We talked about recruitment health center specific data points. We also have 4 of these recruitment service area data points. These measures are just intended to give you a sense of your general service area and the need there for access. It's the type of information that's usually captured by your HPSA score, but in terms of thinking about it through the lens of recruitment, we look at things like the number of primary care physicians per 100,000 population. A lot of times you think about that as an access issue. When it comes to recruitment, we also think of it as a clinician isolation issue. So is it going to be hard to recruit, a primary care doc to your area when they're the only primary care doc in that county? Maybe yes, maybe no. And how are you going to mitigate those challenges? Really, there's no clear-cut right or wrong answer. It's really about giving you a sense and perspective about how you want to start thinking about these problems. So this profile, for example, their number was 34, and they have a little blue flag. So I can already tell you, even without going to the data profile, that they're in potentially one of the more rural areas, and figuring out all the complications that come with trying to recruit into a rural area. Those are big questions that then you can sort of dive into. That's recruitment stuff. When we come to retention, so many retention measures. And these are really the types of measures you are probably most used to tracking when it comes to your human resources stats. So I'm an optimistic person. I'm going to assume everybody on the line tracks things like time to fill ratios and, things for patient panels and all of that stuff. But most of the data points on this section, definitely the ones retention health center data points, all come from UDS. So they're self-reported. It's what you reported into Bureau for 2016 UDS. And really, it's, again, chance to do a little bit of back-end math and algorithms on our side, but to get all of your workforce data in one place to let you look at it through these eyes. So when we're looking at these first 8, you can kind of see little groupings. So for example, numbers 1, 2, and 3 kind of go together. They're looking at what you're asking of your clinicians in terms of productivity. We looked at your patient panel for each of your medical providers, FTE. We also look at your visits per physician FTE, and then we also looked at the ratio of visits for your entire primary care team compared to MGMA. That's that for-profit group again. So those 3 sort of go together and try and tell you a story about what you're asking in terms of productivity. Again, by looking at the numbers on the user guide, you're going to be able to see how that stacks up with other health centers. Number 4 is looking just at your percentage of non-physician providers. This health center, for example, had 82% of their providers are non-physicians. So it's an example of why there's not a rule that you have to have a certain percentage of your providers have to be physicians. Different things are going to work for different organizations. But we put this number in blue because that 82% is higher than probably 90% of the country. So that's okay, but you should know that that's a little bit different, and you should be prepared to talk about and deal with any challenges or opportunities that come from having that number so high compared to others. 5 and 6 also go together. They're looking at clinical support ratios, again, things that you probably, in terms of health center operations, regularly review, but thinking about what those clinical support ratios are for your teams, both medical and dental. And then 7 and 8, they're going to go with some on the next page that we'll, on the other side, that we'll get to. But year-end staff count really tracks it's full-time versus part-time is really what this is tracking, and you can spend some time with the user guide to get a good handle on that. But what it does is it compares the number of physical people on your staff in that position, so for this example, physicians, compared to the number of FTE you have. So if you have 5 physicians on staff and you have 5 physician FTE, that number is 1. The closest you are to 1, that means you're close to a full staff of full-time people. So if you get lower than 1, that means you have some significant vacancy challenges, right? You don't have enough people for the FTE that you said. Sometimes that happens just with, timing in the data. If you have a high number like this 1.95, that means you probably have a higher percentage of part-time people. So this is another example of how none of this is really a judgment call. A lot of part-time people could be great if you're intentionally using part-time positions to retain people over a long period of time, over their many life changes, whatever. But if you have a lot of part-time people only because you can't find full-time people to hire, that's really when it's a problem. And so that's really, again, I'll say, context is really the key to understanding, what is this data point actually telling me? And is this identifying a place for intervention? So that's what the year-end staff counts are. They're really looking at that full-time versus part-time mix. And you'll see those down here, number 14, 15, and 16 as well, are year-end looking at different types of folks. And just quickly to wrap up this section, we have average tenure months staff count for physicians, and then your NPPA CNM group. My dream, and I'm going to tell you about it because it's what I wish for the world of health centers, is that every health center had a good sense of what their real turnover numbers are for each of their positions. So this average tenure months, that's what's reported in UDS, and that's really you telling BIPIC, this is the average number of months that all my physicians have continually been in their position. So for example, if you have a physician who becomes a CMO, that physician's been with you for 5 years, and then they become a CMO, that's not captured in this data. And that's really a restriction of using this UDS number, and it's really just a proxy for what I would love to have, which is live turnover data from all the health centers. So I'm going to say that just to put that bug in your ear, to be thinking about things like this when you see it. What are our real numbers on a day-to-day basis, and figuring out how you can start to use those in your own dashboard. And then last, I just wanted to mention numbers 12 and 13, which were clinical quality issues. Sometimes people are surprised to see clinical quality issues on our, recruitment and retention profiles. But really, you certainly know, it's not a surprise that the general sense of satisfaction, burnout, not burnout, turnover, et cetera, is absolutely related to anybody's quality of life and day-to-day. And so clinician burnout as it relates to ongoing, we'll say, comorbidities or just different challenges in dealing with a tough patient population can absolutely contribute to clinician turnover. And so we wanted to snap you back, help you look at these numbers with some eyes to say, oh, these numbers are where we want them, or they're not where we want them. And how does, having this high percentage of uncontrolled diabetics affecting our folks' general feelings of that they're making a difference, and that everything they do at work is useful, and that they can take good care of their patients, which is what they really want to do. It's why they're there. So you'll see that stuff also in the last section, which is the retention service area stuff. And these are just a few service area data points that look at things that we also think could connect to burnout and quality of life issues. So for example, percentage of the population in your service area with non-medical use of pain meds. I don't need to talk to you about what's going on in terms of the opioid crisis in this country and how it's affecting clinicians' ability to do their jobs and feel effective. And so all of this is really, even though you may not necessarily consider it recruitment retention information, it's an opportunity for you to look at all of these numbers with fresh eyes, with recruitment eyes, and with retention eyes as well. And so when you get your profile, you want to start on this front page, and this is what you want to do. You want to take it, you want to look at all the blue flags, you want to look at your user guide, get a good sense of what's going on there. Next, you want to go to the context piece. So what is the context? Why is that number that way? What's happening here? And then next, you want to go to the solution. So, okay, what's our concrete challenge we're going to try and accomplish and deal with now? So we've done some of that blue flag work. We looked at the front. Next, we want to quickly flip to the back page to talk about that context piece. So as I mentioned, you at your individual health center are going to have a lot of that context about what's going on and, oh, we opened a new site, or that's because that, nurse practitioner left right at the end of the year before we submitted UDS or whatever. But it's very exciting to say this is the first time after doing this project for many years that we have multiple years of data where you can identify trends. And that's really helpful as you're trying to figure out how to make sense and how to prioritize over here. One quick note is that we did not have data profiles in the year 2016 using 2015 UDS data. So prior report is using 2013 data, prior report is using 2014 data, and current report is using 2016 data. So there's going to be a little bit of a gap here sometimes in between prior report and current report. So that's just to let you know, but because now that's several years, you can still start to see some trends. So for example, let's go back and look at that one we were looking at, number 6. It's those vacancy questions. In 2013, this health center didn't have any vacancies posted on the National Health Service Core Job Board for physician staff. In 2014, they were in a blue flag then because they had, compared to their current staff, 38% of their positions were vacant. Ooh, and then you flip back to this 195. So I would say probably that 2015 year we're missing was somewhere between 38 and 195. But you can see that this is something that's been a persistent problem for this health center over the last couple of years. So something to kind of keep in mind as you're looking at these trends here. When we look at the retention ones, that's also pretty interesting. We want to kind of examine things with the context of a few years data. So we're going to look at number 4, for example. That was another one that was in blue. Percentage of their providers that are non-physician. So in 2013 data, 60%. Stayed relatively stable, and 2014 data, 69%. By the time you get to 2016, it's 82%. So what I'm seeing there is a gradual but a distinct trend toward employing more and more non-physician providers. Again, there's nothing necessarily wrong with that. If that's part of their general, PCMH quality initiatives and how they're sorting payments and how they're staffing and the needs of their organization, then that's great. But if, they're only doing that because they can't find physicians, which is what I'm guessing based on what we were looking at the earlier part of the profile, then that's something that you sort of need to talk about. So we can also see some things down here as we're talking about that physician issue. We did that average tenure of months, and you can see a big drop-off between these 2 years. Now, again, that 2015 data is missing, but still, to go from 97 months to 58 months, that means you had to lose at least a couple of people to lose those months off there. So it could have been a big exodus, which is what's causing the large number of vacancies now, or it could have been, something small, somebody, because, UDS itself is an average, maybe it was someone who was there for a really long time. I don't know, that health center will have the context to really understand and unpack that data. I don't know if y'all have ever seen that show, Deal or No Deal with Howie Mandel. It's the one with the suitcases. Think of each of these numbers and these data points as a little suitcase. You got to unpack it. You got to see, oh, what's behind that number? I need to know. And that unpacking job that you're going to do with your team is the important piece. The process is really important here. Really, as I mentioned, context. The data is just one piece of it. It's a starting off conversation. You want to add to that your context after you've had some chance to go through the data, and then move there to some concrete issues and solutions. So I know your head must be spinning. We've covered so much of, I keep saying, data and context and issues. I wanted to take our last few minutes before we open for questions to talk through how this would actually work. Like if I were a health center and that was my profile, what would that actually look like? So we've done some of the work today together. Let's say you received that profile we just looked at, and after a longer review than we took, but some review of both the front and the back, a review of the data points and the user guides, you realize that many of the issues in your data are pointing to a specific challenge with physicians and physician turnover. So you looked at your data, you went back and looked at data that you had also at who's leaving, and you see, hey, based on this data profile, I see in our National Health Service Corps vacancies that we have an increasing need for physicians. Our average months of tenure is going down, people are leaving, and we're hiring a larger percentage of non-physician providers, not because we want to, but because it's taking us 3 years to fill these physician vacancies. So you used the data profile data, and you brought your own context to say, hey, based on all of this, I think we want to start to address physician turnover. So that's kind of when you launch into your plan. That's your major issue you want to pick as your investment for this year. So you've identified that as what's happening. Your strategy is asking the question, now what? So that's really when you want to do that data review we were just talking about. And also spend some time thinking about operations. So, okay, we know this is a problem. We're going to come up with a plan to do it. How also then do we mitigate any other challenges that will come from it in this period? So, for example, all of a sudden now you're employing a larger number of non-physician providers than ever before. Does anything in your practice flow need to change to accommodate that? How have you considered changing any of your scheduling or your primary care teams or your payment issues? How is any of that getting changed to adapt to the new reality? Let's just say it. You're in that reality now. How are you dealing with that while you're focusing on your turnover issue? So next, what's the recruitment hat you need to wear for this problem? Let's say you say, hey, I know what our problem is. We need to just recruit more physicians. Now in this very difficult funding time and very competitive marketplace, now is not the time to do business as you've always done it. So I would say if you're having challenges reviewing recruiting physicians, then now's the time to review your recruitment plan for those physicians. So that would be a good time that you would say, okay, we're having troubles with physician recruitment and definitely turnover. Let's figure out how we're reaching out to people. Where are we sourcing? How are we conducting interviews? How are we actually bringing people on board in an appropriate manner so they feel comfortable here and don't leave after 3 months? So this is when you would spend some significant time updating your recruitment process. I'm happy to say that the STAR Center has a free, yes, I said it, free recruitment and retention plan template that you can use, a series of tables already designed for you. So you can say, oh, I'm going to go get that free resource from the STAR Center and update my recruitment process and start to do some things differently. And while I'm doing that, we wanted to focus on the turnover part. So on that retention piece, how are we supporting staff? I won't say more because we're about at question time, but stay interviews are a great concept now that we know several health centers that have used them successfully to interact and create better engagement and management relationships and talk with clinicians and other staff about what's working for them, what's not working for them, what's energizing them, what's really a challenge for them, and just get a general sense of why have they stayed so far and why do they want to stay and what are those barriers to staying. And so maybe you will unearth some things during those stay interviews with all your staff and especially your existing physician staff to say, oh, this was maybe a problem. This was what was contributing to our physician turnover. And I know now how to keep the people that we have, and I know how to account for keeping the new people that we're going to recruit through our great new process. The last thing always is realignment. So you would want to say, this is a project. This physician turnover thing is a project we're doing over this many months. And you want to do your classic plan, do, study, act cycle with this as much as you would do with any clinical intervention you're trying. So set some goals, study it along the way, review your data, and then kind of align, realign, fix, move on, whatever the case may be, to keep making those improvements so that you can start to pick. So if you had one thing that you were going to invest in, you could use this data profile to say, oh, I know what the big problem is and I know how I'm going to invest in it. So your next steps, now that you have your data profile, review that profile and user guide, complete your self-assessment tool. And I've sort of mentioned the self-assessment tool just briefly right now, is that we have that. It's free. It's on our website. And that's going to give you some great other background, some other data for you to compare with your profile and your user guide. And you can also call us. Schedule a call for a review of your specific profile, and you can request technical assistance. Maybe you totally understand the profile, but you don't understand how to put it together. That's also fine. We have lots of workforce experts here, and we are ready to help you and take you through this process. So I'm going to stop here and see if we have any questions. I know one question that came in was about our state roll-ups. So we are going to do state aggregate reports again and share those out. Those are going to be coming in mid to late January. So sorry for the little bit, the holidays sort of slow things down. Sorry for a little bit of the delay, but we will have state aggregate reports available for everybody, and then state packets and those state roll-ups available for PCOs and PCAs that sign their data use agreements. They will be coming in mid to late January. So any other questions we have on the line? Now's certainly not your last chance, but your last chance before we hang up right now. Seems like the rest of the staff have answered all the other questions offline. So to that, I'll just say thank you so much, for your time and attention today. Here's our contact information. I hope you will stay in touch and reach out. Please call us anytime. We love talking data. We love talking strategy, and we'd love to talk about a specific plan for your health center. Thanks.